Daily news and analysis. We keep you informed and inspired.
This is World Today.
Hello and welcome to the panel discussion of World Today. I'm Ding Heng in Beijing. It's been nearly a month since the World Health Organization declared the Ebola outbreak in the Democratic Republic of the Congo and Uganda a public health emergency of international concern. The numbers of confirmed cases and deaths are continuing to rise. In a situation facing a lethal pathogen and zero approved vaccines, what does it take to stop the spread of the virus? This question and much more in this edition of the program. To listen to this episode again or to catch up on previous episodes, you can download our podcast by searching World Today. So joining us now on the line are Susannah Mayhew, Professor of Health Policy, Systems and Reproductive Health at the London School of Hygiene and Tropical Medicine. Shane Thomas, Professor of Health Promotion with Federation University, Australia, as well as Professor Wu Zhiwei from the School of Pharmacy, Dali University in Yunnan, China. So thank you very much for joining us, Professor Mayhew, Professor Thomas, and Professor Wu. Professor Mayhew, to start with you. So far, what do we know about this Bundibugyo virus strain behind the current Ebola outbreak?
Well, I'm not a virologist, but as I understand, we know this is a newish strain. I think identified in 2007. It's not as highly fatal as the Zaire strain, for instance, or the Sudan strain, but there is no vaccine at present. So we have only our, if you like, our sort of traditional default means of combating this, which is screening, monitoring, testing, contact tracing, and isolation and quarantine. But I'm sure we'll come on to these bigger issues. But what will underpin all of those is maintaining trust between people and health workers. So it's something to be worried about, but also not to panic about.
Professor Wu, going to you. Anything to add regarding what we know about this Bundibugyo virus strain? And as Professor Mayhew mentioned earlier, this particular strain we're talking about here was actually first identified in 2007. Can you help explain to our listeners why today we are still yet to develop a vaccine or treatment for it?
Well, I think one of the major reasons is that this virus is never a major, epidemic threat in Africa, the Ebola outbreaks, because as the earlier speaker just mentioned, that it actually only happened twice. The first time was in year 2007. The second time was in year 2012. Both outbreaks happened in the same region, but the both outbreaks actually were relatively small scales. So that's why it actually hardly raised people's attention. And that's the other reason is that in the African region, the Ebola outbreaks mainly were either by Zaire or Congo subtypes. So that's one of the reasons why the current vaccines and the therapeutic approach basically aimed at the Zaire subtype. So when the first case occurred in DRC, actually was misdiagnosed because there was no such specific diagnostic kit for this virus, and that actually causes one of the problem in the early spreading, because people did not realize it was an Ebola outbreak. So this is something actually I think we now need to put a lot of effort and attention in this region for those much less noticed virus strains, because Ebola there are 7 different subtypes, and this is only one of them.
Hmm. So you mentioned about misdiagnosis. I guess that's because the initial symptoms of Ebola infection is to some extent similar to the symptoms of many other diseases, right?
That's right. Yes, clinically, actually, the early stage, we call the stage one. Actually, many of the clinical symptoms are very similar to kind of common fever and a
Hmm.
little bit of diarrhea. But only when you enter the second phase, actually, you see a multi-organ complications. Those actually would raise people's attention and suspecting whether this is something relating to Ebola sickness.
Okay. Professor Shane Thomas, going to you. What do you make of the main challenges for developing vaccines for this particular Bundibugyo virus strain or Ebola in general, in terms of funding, in terms of logistical issues, or other issues?
Well, as my colleagues have said, this has been a relatively rare condition. It also has slightly less kind of fatality than some of the other strains, 30 to 50% essentially, and which is lower than the more lethal strains. I think also it's been in a kind of relatively geographically limited kind of areas. So it's not downtown New York or downtown Beijing. So I think that there's been a tendency to kind of not be so concerned with it. It's also not highly prevalent, even now. However, it certainly has our attention. So I think that in terms of the challenges, one challenge is self-correcting in that it's becoming more prevalent and it is fairly lethal. So we certainly need to pay attention. COVID has taught us a lot about the management of pandemics, and this is very far from a pandemic, but we have much improved technologies, much improved means of developing vaccines. So I think that in all of the history of humanity, we're probably in the best shape that we've ever been to deal with these sorts of challenges, but it is an enormous problem. I might just mention something personally. I one time developed a very simple viral infection, a thing called cytomegalovirus, which, if you're in Asia, almost everyone has had, but in Australia, it's a relatively rare condition. Came back from the US with it. And in fact, I was put in an open ward in a bed next to a guy who ultimately developed Ebola. So that was very exciting for me because, the very rare condition then. But in fact, we then went into deep levels of isolation once it had been diagnosed. So I have a kind of personal interest as a consumer in this condition.
Hmm. Okay. So, Professor Mayhew, what is your observation regarding the major challenges facing vaccine development, and do you share this, cautious optimism on the part of Professor Thomas?
Um, yes, I mean, I think there are, I think there are big sort of political challenges actually around developing vaccines for what used to be called neglected tropical diseases. As Professor Thomas said, the prevalence is not so high, and that means that there are relatively small numbers of people, which means that there's actually relatively small market incentive for
Hmm.
big pharmaceuticals to develop drugs for these kinds of diseases. And we know that when the West Africa outbreak happened so catastrophically, and there was a shift in commitment to needing to do something. But I must say that commitment only came when Western aid workers were affected. And then we saw a lot of money being given to very small laboratories who had for years been trying to raise money to develop these vaccines. So they had a lot of the initial work done, but they couldn't raise money to take it to scale. So, and the other interesting thing about the Ebola vaccines is that in the 2000s, there was more of an interest in broad spectrum vaccines dealing with families of or different strains in one, if you like. In the 2010s, that seemed to shift to being more focused on single strain vaccines. And again, that may be a function of the money available. I don't know. There was an interesting paper, though, published just a few weeks ago by a team of Chinese researchers, once again looking at the possibility of broad spectrum vaccines. So that's very welcome. So I think, we need political commitment, but we need that to be followed with funding if we're going to encourage pharmaceuticals to invest in these sorts of lethal, but at the end of the day, diseases that affect relatively small numbers of people and for whom there isn't really a natural market. So that's been a big challenge, I think.
Okay. Professor Wu Zhiwei, for the current Ebola outbreak, should the world wait for a vaccine to act, in your opinion? I'm asking this question because I see some people, some experts having this point saying vaccines are the great hope, but not the immediate rescue. Do you agree with this point?
Well, I would have to agree. I think this basically sees the nature of a vaccine in terms of preventing an epidemic or outbreak. I mean, both Professor Mayhew and Thomas mentioned that this outbreaks actually is quite rare, and the market could be small, but there is another serious technical aspect as well, because once you develop a vaccine in the lab, you need to go to human trial. If an epidemic actually happens rather randomly in a small region and not that many predictable potential target, then the clinical trial would be a huge problem. That's why when the COVID-19 happened, that there are a lot of commercial companies jumping in trying to develop vaccines for a number of reasons. One is that because the epidemic is so concentrated, clinical trial would be much easier to carry on. The second is that the market is huge, and you have to admit that for the big farmers, they are looking at the end market because they want to recover their investment. So for all the breaks like Budibongia virus, it's actually relatively small. That's why the early vaccine for Ebola virus is targeting the Zaire virus, because over the history, if you look at the African epidemics of Ebola virus, basically it's the Zaire subtype. But I think this is more important that the government should take an initiative, or the international health organizations like WHO. It's something actually we need to have a multi-country coordination, led by international health authorities like WHO to see whether you could have a vaccine put into the pipeline and develop basically for the preparedness in the potential outbreaks.
Professor Thomas, many people in Eastern DRC are quite familiar with Ebola from its previous outbreaks, actually. But for the current outbreak, we're talking about a different Ebola strain for which there are currently no approved vaccine or treatments. So with that in mind, do you think this assumption on the part of many locals that they thought or they think they know Ebola well is actually complicating the outbreak response?
I think that globally there is a fatigue with pandemics and virus outbreaks that has occurred with COVID and the complacency that has developed. So if one looks at the vaccination rates, they're actually quite low in many countries because people have just become tired of attending to this. That said, when you have a virus strain with a 30 to 50% mortality, that is serious. So it requires serious attention. Both professors have referred to the availability of well-established public health programs, with prevention and mitigation and treatment, but also, and the process of screening and monitoring and so on. So I think that if we were not to go down that track sort of vigorously, that would be really at our peril. So we certainly need to pay attention while recognizing that we don't have a neat kind of vaccine solution at present. You know, each of the major pandemics that has confronted humanity started with one or two cases. And then they grew HIV, COVID, others to be very important pandemics. So we need to watch ourselves. We need to pay attention. We have well-developed approaches to prevent and mitigate these conditions, and we should be making sure that we are applying them rigorously.
So I guess this fatigue or complacency you mentioned from human beings feeling, natural feeling, that's understandable. But science tells us that we cannot be fatigued or complacent, I guess. So Professor Mayhew, the 2014 to 2016 West Africa Ebola epidemic was the worst Ebola outbreak in recorded history. At the time, there were more than 28,000 reported cases and about 11,300 deaths. And in a new study published recently, the U.S. Centers for Disease Control and Prevention models the current outbreak in Central Africa. According to some scenarios, the ongoing outbreak in DRC and Uganda could rival the one a decade ago in West Africa. For example, the study projects that if only 20% of the patients during the current outbreak are isolated, then there could be a 65% chance of case numbers exceeding 20,000 within 3 months. How do you look at this analysis?
Yes, I would be somewhat cautious. They did modeling in the early part of the West Africa outbreak, which actually wildly exaggerated the potential spread. Now, it was a catastrophic outbreak, and it was the largest, as you said, ever recorded, but it was nowhere near the numbers that they were modeling. So I think we need to be to not panic. This is not it's unlike COVID. It's not easily spread, Ebola. It's spread when you have symptoms, when you're in the so-called wet phase. But having said that, there are many reasons why this outbreak could mirror the scale of the West Africa one, because DRC is extremely volatile. It's an ongoing conflict setting. But perhaps most importantly, there are very high levels of distrust among people, local people, of any kind of foreign intervention. And people on the ground will tell you that actually a foreigner is somebody from the next district. It's not necessarily someone even from outside the country. And I think it's really important that we learn the lessons both of the West Africa outbreak and of the 2018-2020 outbreak in DRC. They were both the Zaire strain. This is a different strain, but the underlying conditions that perpetuate the spread remain. We've got huge population densities, lots of refugees, in a setting where it's very hard to maintain peace. And I think it's critical that any response from external support responders and supporters needs to work with local people and let the local responders lead this. This is what led to the hostility that we saw last time, which we're sadly seeing repeated in this outbreak. We've had, I think, 2 health facilities been burned, and that's a direct consequence of a lack of trust of people in foreign responders who are often conflated with the foreign peacekeeping forces that people feel were not able to protect them. There's widespread suspicion. So vaccines and treatment centers are not effective if people won't trust them and therefore do not come to use them. So what we learned from the West Africa outbreak was the importance of safe and dignified burials and the importance of communicating through local trusted messengers in local dialects and languages. So French and standardized Swahili is not going to work in very localized remote areas. So I think there are a lot of things. We need to be supporting with resources. Mobile laboratories are critical, PPE, obviously, also intensive care equipment. But I don't think the foreign responders should be seen to be fronting the response. This needs to be from local trusted people. And for me, that's the most important thing to keep in mind when we're thinking about how it could scale and learn from the previous epidemics.
Professor Wu, based on what Professor Mayhew has just elaborated, she made a point about a lack of trust, and I guess it's in the meantime, it's also fair to say that many communities in Eastern DRC are dealing with more than just Ebola. They are also faced with malaria, measles, poor sanitation, lack of clean water, displacement, insecurity, etc. So do you think Ebola can be effectively contained without addressing those other daily challenges for the locals as well?
Well, I fully agree with Professor Mayhew's point. I think in the DRC, the armed conflict that's been going on for continuously for more than 5 years. One of the issues, actually, the consequence of this conflict is that the local people actually have very little trust and they're highly suspicious of the outsiders. The other thing is that the conflict also causes the dismantlement of the local health or the medical infrastructures. So that's why the local containment capability is severely weakened. That's really something actually worrying the public health workers. So for a virus which actually without a specific diagnostic kit and without treatment approach, I think one of the issues currently actually it's very urgent is that you do the contact tracing and early identification of the infected. The contact tracing, I mean, historically, actually, we use various different ways, such as interviews and the household visiting. Those actually requires trained individuals to do it. So that's why the trust became a very important issue here. I actually read in the reports that because both DRC and Uganda actually bordered with 10 other African countries. Actually, in the end of May, there are 2 identified cases in Kampala, in the capital of Uganda, suggesting that this virus may actually spreading out into densely populated cities. This is something actually I think it's very important in terms of such as border surveillance, border cross control. Those issues actually in a way also hinders international aid floating into those 2 infected countries. So how this could be coordinated? It needs a lot of government, international NGO and other health authorities to coordinate to make the local action more effective.
Thank you very much. And let's take a very short break here. And coming back, our discussion will continue. Stay tuned. You're back with World Today. I'm Ding Heng in Beijing. Today we are discussing the current Ebola outbreak in Central Africa and what it takes to put an end to it. Joining our discussion, Susannah Mayhew, Professor of Health Policy, Systems, and Reproductive Health at the London School of Hygiene and Tropical Medicine. Shane Thomas, Professor of Health Promotion at Federation University, Australia. Professor Wu Zhiwei from the School of Pharmacy, Dali University in Yunnan, China. Professor Shane Thomas, going back to you, we know at present less than 2/3 of the contacts in the DRC have been successfully reached. WHO Director General Dr. Tedros Adhanom Ghebreyesus said recently that this figure needs to increase to more than 90% and even about 95%. What do you make of the main obstacles for tracing and reaching contacts?
Well, I think Professor Mayhew is referring to the necessity for involvement of local workers in that process, rather than foreigners coming in and seemingly assessing people. The screening function is very, very important, and then the monitoring and tracing is also very, very important. So I don't think there's anything spectacularly complicated about this. You just need people in appropriate number with the appropriate training who have the trust of the local community to do that. And if you don't, you'll have problems. So I think the Secretary General or Director General's wish for a 95% rate is a good wish, but I suppose we'll see whether that's realised in the local circumstances. I think there's quite a degree of suspicion about foreigners coming in and doing health things to locals. So I think we need to be very focused on that.
Professor Mayhew, unlike some diseases or epidemics where the infected people are contagious during the incubation period, Ebola virus transmits only after symptoms begin, meaning a person who can actually, spreads the virus is to some extent identifiable. So considering this very characteristic of Ebola infection, what do you think should be the focus for Ebola response?
Yes, so as you say, Ebola is contagious only after the symptoms begin. But of course, that means you have no real warning of who is infected and who isn't until they become contagious. So I think widespread communication campaigns are really important so that everybody is clear what symptoms to be aware of, to take seriously. So the early symptoms are very often appear like malaria or typhoid. And indeed, in the West Africa outbreak, that's what it was known as at the beginning. Oh, it's malaria, typhoid. It was actually early Ebola where you have headaches and fatigue. And it's not till later that you develop the vomiting, the diarrhea, and so on. Again, I think the messaging needs to be developed with local people. One huge mistake in the West Africa outbreak was that Ebola responders coming in from outside thought they knew what the symptoms looked like. But actually in Sierra Leone, where we were working, the presentation was completely different. There was no classic bleeding, even quite late into the symptomatic stage. And yet it took 6 months to change the official guidance on the symptoms to look out for. So a lot of the early cases were simply missed. And so it's really important that local presentation, particularly of strains where there haven't been so much outbreak, that people really are looking out for the right things on the ground. But the other thing is to raise awareness about the importance of how you handle a person that has developed the symptoms, particularly in areas of widespread mistrust. People will hide symptomatic cases, and we saw this in both of the big previous outbreaks. One thing they developed in West Africa, which most certainly saved lives, the CDC eventually produced a leaflet called What to Do While Waiting for an Ambulance. And this was targeted at caregivers at home, very often women, and we often see death rates much higher among women. And it was also recognizing that in some of the remote areas, the likelihood of them being able to transport somebody to a facility was actually very minimal. And so we have to accept, though it was controversial at the time, that we need to try to encourage people to care for people as safely as possible if transport to an isolation unit, to a clinic is not possible, or indeed if there is such high level of distrust that they would not do that. There are still things we can do to minimize the spread, but only with a good understanding of those symptoms and what you can do to make sure that contact is minimized with other people.
Okay. Professor Wu Zhiwei, we understand late last month, Uganda decided to temporarily close its border with the DRC to limit the spread of Ebola. And during a recent visit to an Ebola isolation unit in a hospital in the capital city of Uganda, WHO's Director General, while he praised Uganda for its effective Ebola response, he also called on the country to reconsider its border closure. He said blanket travel restrictions don't work. What is your take regarding Uganda's border closure?
Well, the border surveillance and the closure are, the ways to prevent the spreading into other countries. But basically, the blanket border closure is not a way to contain the epidemic because if you look at the geographic region in that actually from the Uganda and the other countries actually from Eastern Africans, it's relatively easy to reach the eastern part of the DRC. So there are a lot of international aid actually is heading towards that direction. If the border is completely closed, many of the needed equipment like mobile labs, diagnostic treatment facility, and the safety equipment would not be easily reaching DRC, which is the epicenter of this epidemics. So I think this is something actually the regional countries should consider kind of coordination among different countries, basically trying to contain the epidemic. I think this is very critical that it's the same as the COVID-19 outbreaks. It's not a one country's problem, it's basically a regional problem.
Professor Shane Thomas, in Kenya, we understand the United States is setting up a quarantine facility in the central part of the country with a purpose to quarantine and observe American citizens who have had a high-risk exposure to Ebola. And we know currently within Kenya's national border, there is zero cases of Ebola infection at this point. So many Kenyans worry that this might bring the virus into their country. Does this represent a legitimate concern, in your opinion?
Well, I have to say that it is surprising that the idea would be to have citizens from one country being cared for in another country. The idea being generally that it's the government's responsibility for the country for which you're a citizen to pursue your well-being and treatment and healthcare. So it's kind of a surprising proposal. I think in terms of whether it's a risk or not, depends very much on how people appear at this facility and also the investment into the clinical and material resources of the facility. It's not something that I personally would want to do. If I were a person who was infected or at risk of being infected, I would prefer to be treated in my Western or advanced kind of health service. So I think it's a surprising suggestion. I think the actual, but to take a sober look at it, I think the risk would be minimal. So I don't think it's a particularly good idea, but I don't think it has high risk associated with it if it were run properly. But we don't have those kind of details, as to what kind of clinical supports would be brought in and how people would be transported into that arrangement. The devil is in the detail.
Devil is in the detail. Professor Mayhew, what is your thoughts regarding this? I mean, apart from those local Kenyan citizens concerned about the spread of the virus into their national border because of this U.S.-built facility, some epidemiologists in the United States, in the U.S. home soil, have also expressed some reservation about setting up a U.S. quarantine center in Kenya. They argue it's actually cheaper and safer to just transport people back to the United States because it's better for individuals to quarantine closer to a potential biocontainment care unit that has a higher quality of medical care than, say, at a randomly set up field hospital. Do you think this rationale has a point? Why or why not?
Yes, I think it does. As Professor Thomas said, the devil's in the detail. It could be perfectly safe to take people to Kenya to put them in a specialist unit, but that will cost a lot of money. Why create a whole new unit in a different country when indeed you could transport people? And on the very human level, as if you were sick, you would surely want to be treated closer to home. This was one of the reasons why people in the West Africa outbreak actually did not want to go to isolation centers because they were a long, long way away from where they lived. No family members could come to see them. So I agree, it's a very surprising move. And at the moment, they're talking about quarantine and observation. But indeed, what if people go on to develop full Ebola? Now, if you're going to treat that in Kenya, you need a whole, as you say, biocontainment unit. Now, that would cost a lot of money. So indeed, I think it's far more sensible to then transport people safely, which we know has been done. This is what the European health workers have done in previous outbreaks. And we have facilities set up to deal safely with people at very high risk. So I agree with that assessment, and I hope that they will rethink this. It doesn't, I think, help improve the image of America in the world. So I think it would be a good foreign policy choice as well.
Yeah. Professor Wu, I guess when we talk about this U.S. Quarantine facility in central part of Kenya, I guess a guiding principle or a kind of underlying idea guiding the building of this facility is that, okay, Washington or the US government wants to create a geographic distance between the virus and the US home soil. Do you think this idea is viable? Does that work?
I can't speak for the policymaker in this point. I think this is a possible point that for a highly contagious virus like Ebola virus, actually, if you have a geographic separation, definitely this is an important psychological factor in terms of where you put your patient and the people living nearby, or I would think that you don't want to put a bunch of patients in your next door. I think that's probably is a consideration. But as Professor Mayhew and Thomas mentioned, in my personal point and from the clinical point of view, that this is definitely not the best approach in dealing with this disease. Of course, from the cost point of view, this may be a lower cost because the outbreak may be continuous, and the infection or the contact of individuals, American citizens, may be not just happening at the same time. If they were transported back into the States, then the transportation and along the way the maintenance care cost would be extremely high. So I think that's one of the reasons why they set up a quarantine site in Kenya. So this is basically my take of what is happening right now.
Okay. Professor Mayhew, it is widely acknowledged that countries affected by the 2014 to 16 Ebola crisis benefited a great deal from international support. Compared to the situation back then, how does the scale of international support look like for the current outbreak?
Well, I was pleased to see that WHO called it an emergency of international concern early on in order to trigger international support and funding. I don't actually know how much has been pledged for this outbreak, but I imagine we'll see similar trends to what we have seen before. So we did an analysis of the OECD reported funding to Sierra Leone before, during, and after the Ebola outbreak in West Africa. And what we saw there was indeed a very substantial increase in aid, but actually rather late. It was only towards the end of the first year of the epidemic that it was really triggered in significant proportions. And arguably, you need it in place, immediately, really very early in the epidemic. And the other striking thing was that as soon as the epidemic was declared over, the funding fell off right back to where it had been pre-Ebola. And the problem with that is that there's no money for recovery because obviously an outbreak, a catastrophic outbreak like that has huge knock-on effects to the capacity of the health system, which is already weak. And really, you need a much longer term commitment to building up and strengthening facilities after as well. Richard Horton, the editor of The Lancet, called that lack of continued funding yet another episode in the betrayal of Africa. And cynically, I don't expect to see anything very different this time. I think there will be significant funding triggered for the outbreak while it's happening, particularly if foreign medical workers are at risk, but then we'll see it stop. Meanwhile, the country has to deal with the after effects. So sadly, I think we need much more, much earlier, and for much longer.
Professor Shane Thomas, talking about China, we know recently a Chinese team of medical experts arrived in the DRC for a 3-month frontline mission to help contain the outbreak. During the 2014 to 2016 Ebola crisis in West Africa, many people would agree that China made extensive contributions to the international effort that eventually put an end to the spread of the disease back then. How much contribution is China capable of delivering this time around, in your opinion?
Well, I think this approach is a lesson to us all, and it's a matter of putting your money where your mouth is in terms of support for our colleagues and our partner countries. So I think this is commendable. In terms of the investment, I'm unsure as to the quantum that China will deliver, but I'd have to say this is a very good start. I think what it means is that other countries also need to step up, either by provision of direct services or by funding, or both, in order to assist the situation. I'm also aware that Médecins Sans Frontières are also attempting to involve themselves in this. So there are other agencies, not at the kind of national level or country level, but that are global, that are involved. I think that underinvestment in early attack on this problem is a very big mistake. As we've heard from my colleagues, the drop off in investment when you believe that you have escaped from the initial bad effects is also a mistake. So I think that what we have learned from our experiences across a range of conditions, and also in Ebola specifically, is that acting late and acting with insufficient resources is not in your interests. We need to change that pattern.
Professor Wu, what lessons do you think we have learned from previous Ebola outbreaks? And do you think those lessons are still relevant when we talk about coping with the current outbreak?
Well, I think, in the previous outbreaks, we learned a lot from the epidemics, and also international collaboration in containing the virus. I think this says that basically it's all the same for the current outbreaks, because if you look at the current situation, actually, as Professor Mayhew mentions, that the international organizations should also, step in and taking certain initiative by mobilizing the local communities in joining the containment. The WHO and those organizations, I think one of the issues right now they're facing is that the severe funding shortage as the US withdraw from the organizations, and also there are many different programs will cut down and shrink to smaller scales. So to coordinate this containment of the epidemics, you need to not only the international organization, but also the local stakeholders to join it and to studying this campaign. I think, if the international organizations and the local countries and communities actually have actively involved, we will be able to, in the shortest time, to contain the epidemic.
So, Professor Wu, since you join us from a Chinese university, what do you make of the resources that China could possibly contribute?
I think there are two aspects. One is that, as you just mentioned, China has sent off an expert team into the field to deal with the epidemic. The Chinese experts actually have a lot of expertise in this area, because in the previous major outbreaks, they actually deeply participating in the local activities. The second is, as I already know that in China, there are a number of research groups, including my own groups, actually starting looking at the Bundibugyo virus. We're trying to identify the serology and also to look at the virus basic biological characteristics and trying to see what actually could be a potential, the vaccine to develop instead of just looking at some more basic research, but also we're trying to look at the antibody response to see how we could develop diagnostic kit to be quickly utilized in the future in all the breaks. So those are something actually the Chinese side could contribute to the African Ebola or the breaks.
Best wishes and best luck to your own research, by the way. So, Professor Mayhew, we know Ebola was first discovered in the 1970s. However, there have been more epidemics of Ebola happening in the 21st century than compared to the period between 1976, when it was first discovered, and the late 20th century. What do you make of the underlying issues for this trend?
Yes, thank you. It's a really interesting question. So Ebola is a zoonotic infection, so it spreads from animals to humans, in this case, most likely bats, although Ebola is also present in other animal species. And I think there are a number of potential explanations for the increase in the number of outbreaks we see. One is increasingly human populations are moving into wildlife-rich areas. And part of that is population displacement, a certain extent of growth, urbanization. And that means people come ever more frequently into close proximity to wildlife. And the other thing that influences that is climate change. Climate change is affecting patterns and behaviors of wildlife. It's affecting habitats. And again, wildlife is being pushed closer to humans. And as long as this continues, we will see a much greater potential for zoonotic spillover risk from animals to humans. Of course, we also have better diagnostics. So some of it may be that we're simply identifying it correctly now as Ebola when previously perhaps it wasn't, but it's the denser spillover risk, but also the transmission risk. So we're seeing bigger outbreaks as well as more frequent ones. So it's important that we keep doing research on the nature of zoonotic spillover risk so that we know how to prevent it.
Well, a big thank you to our panelists, Professor Susannah Mayhew from the London School of Hygiene and Tropical Medicine, Professor Shane Thomas joining us from Federation University, Australia, as well as Professor Wu Zhiwei from Dali University in Yunnan, China. That's all the time for this edition of the program. To listen to this episode again or to catch up on our previous episodes, you can download our podcast by searching World Today. I'm Ding Heng in Beijing. Thank you so much for listening. Bye for now.